Hello, and thank you for joining us on MedEd Talks. You're listening to the podcast series RSV Immunoprophylaxis, an obstetrician's guide to enhancing comprehension and counseling. This continuing education activity is provided by Vindico Medical Education and supported by an educational grant from Sanofi. For program details, including how to claim credit, please refer to the episode notes or the CE information. And now, here's your host, Dr. Kevin Ault.
Hello, I'm Kevin Ault, professor in the Division of Obstetrics and Gynecology at Western Michigan University, Homer Stryker MD School of Medicine in Kalamazoo, Michigan. I'm joined by my colleague, Dr. Alexis Gimovsky, associate professor in the Department of Obstetrics and Gynecology at the Warren Alpert Medical School of Brown University and specialist in the Division of Maternal Fetal Medicine at Women's and Infants Hospital of Rhode Island in Providence. Welcome, Dr. Gimovsky. Today, we will be discussing interprofessional and patient communication strategies to address concerns about RSV immunoprophylaxis and with women who are pregnant. So we'll start off with a pretty common question. What are the most common causes of hesitancy and misconceptions that pregnant women express about RSV prevention?
First of all, thank you for having me. Happy to be here. When I talk about patients about RSV prophylaxis, the most common concerns I usually hear about are patient safety, particularly when giving something in pregnancy that, could potentially harm their baby. And some worry if this is a new vaccine, we don't know long-term effects. Others ask if they can just wait and have the pediatrician give a vaccine or monoclonal antibody after the baby is born. And then, of course, we see broader vaccine hesitancy themes, such as mistrust of the healthcare system or general overwhelm with all the different recommendations in pregnancy. So I think the key is to kind of validate their concerns. That's an important question. You're not the only parent wondering about it. And then I usually explain this is passive immunity, just similar to how we give the Tdap in pregnancy, and we're giving the baby antibodies for those first vulnerable months of life. So I think reassurance and clear explanations help with some of the misconceptions.
Yeah, I think you hit the nail on the head. If you do enough surveys of pregnant people, one of the things you find out is protecting the newborn is really a priority for pregnant women. So are there any cost or insurance coverage issues with RSV immunoprophylaxis agents?
So I believe there are some cost and coverage issues, especially since the vaccine and the monoclonal antibodies are relatively new. I know that coverage is expanding, but not always consistent, especially amongst private payers. And out-of-pocket costs could potentially be significant if it's not covered. But most people with Medicaid and CHIP will be guaranteed coverage. So when I counsel patients, I try to keep the financial discussion pretty simple that, most insurance plans cover this now. We'll check before it's given. And I don't want to overwhelm families with financial details, certainly in the exam room. So I frame it as we'll help you navigate the logistics of your finances, and you focus on the medical concerns for you and your baby.
I think one of the issues that we talked about was coverage issues, and now we have 2 monoclonal antibodies, and that should help. But, 2 years ago, we had lots of coverage issues and payment issues, and hopefully that's better now. So you actually kind of led me into my next question. Why is it important to initiate counseling about RSV prevention before 32 weeks of pregnancy?
Especially in the fall and winter season when we're giving more vaccines, flu vaccine, COVID vaccine, and then the standard Tdap vaccine. And now with the RSV vaccine, there's a lot to talk about with pregnancy and vaccines. So I think that the earlier you start this conversation, the easier to have. So people can start thinking ahead and have time to ask questions, do their own research, and make a decision. So I try to, pair it with the thoughts of the Tdap vaccine around 28 weeks. Hey, you're getting the Tdap vaccine. This is the time we give this. But, over the next couple of weeks, we'll also start discussing another vaccine, the RSV vaccine, which is given a little bit later on.
Yeah, and around that same time, patients are sitting around the office for an hour for their glucose screening test, too. So if you have written or online materials, you can give them that. I think one of the criticisms and potential research opportunities for us is we should be doing qualitative research and talking to pregnant people about how they feel about 4 vaccines, because I think you're exactly right. We're going to give COVID vaccines and Tdap pertussis boosters throughout the pregnancy, but now we have flu and RSV plus a new COVID vaccine. So we have everything kind of piled on top of each other here at the end of September when we're recording this.
And I want to add that it's also, I think, confusing for patients because the vaccines are timed based on the different gestational age. And so I think I get questions about why is this vaccine given at this time and this other vaccine given at another time. And I think that's also creates potential confusion there.
Yeah, I mean, this is a nice segue to our next question. And you kind of brought this up a little bit. How can OBGYNs like us collaborate with our colleagues in pediatrics and family medicine and midwifery, as well as nursing staff, to ensure that consistent and coordinated messaging around RSV prevention?
So I think this is where alignment and consistency really matter. For example, if an OB says one thing and then the pediatrician frames it differently, this could create confusion and doubt. And what works best is having shared scripts, like clear, simple language that everybody can use. For example, mom can get antibodies during pregnancy that protect baby right after birth, or the baby can get antibodies after delivery. Both are safe and effective. Additionally, nurses are key partners too. They often get the first round of questions, and so equipping them with talking points or FAQs could make a big difference. So I always document in the chart when I've had the counseling conversations so the pediatricians can know what has been discussed at the obstetric appointments.
Yeah, I mean, you raise at least 2 good points. We have to coordinate with this for counseling, but also, if they decline the maternal immunization, we do want them to get the RSV prophylaxis this time of year. And so yeah, let's coordinate that. And it's great that you document that because it'll help out our colleagues. There's a fair amount of data too about I guess I would call it creating a vaccine-friendly space where you do an intervention with your staff and you make sure nobody's telling them misinformation or bad information, and they're fully informed. And of course, you gear that to the schedulers or the MAs, the whole office. And so the 2009 pandemic really kicked off a lot of good research about how to increase vaccine uptake in pregnant people. And that was, I think, one of the consistent and best messages we got from that. So we've kind of already opened up this next question I was going to ask you. Are there any specific tools or structured approaches that you use when you're speaking to patients about these vaccines and RSV prevention?
Yeah, thinking about approaches and tools, I think 3 pretty simple things stand out. First, I use the teach back method. So, can you tell me in your own words how this works, or just so I know I explained it clearly? And that shows to me if my explanation landed and landed appropriately. Second, like I said before, I make comparisons. So this works a lot like the Tdap, a vaccine that most people are comfortable with, where, we give mom antibodies to protect the baby early on that pass through the placenta to your baby to protect your baby. And that's helpful, I think, because familiarity builds comfort and people are familiar with the Tdap vaccine. And lastly, I try to use visual tools like the CDC and ACOG have handouts with simple graphs. We give them to all the patients when they're getting the vaccines. And a lot of people are visual learners and they can observe this information better when they can see it, not just hear it. And of course, some people need to take this information and read it at home first before they accept the vaccine. And that's fine too.
Yeah, one of the points that usually comes up when I'm talking to pregnant women about RSV is most people know what whooping cough is, and most people know what RSV is. It's, a very common reason to be hospitalized. And we were doing a vaccine trial a few years ago, trying to enroll pregnant people in our protocol. And I certainly noticed that women who'd had children before wanted to be in the protocol because they knew all about kids getting hospitalized for RSV, either their own child or one of their friends' childs or their nieces and nephews. So that certainly is a point that resonates with pregnant people and providers too. So why don't we move to our summary and conclusion? So what are some key points you want to leave our audience with here today?
I think that this is an exciting time. I mean, for the first time, we have real tools to prevent severe RSV in infants, and that hasn't been available before last year. And that's pretty exciting to me, especially since RSV is a common reason why newborns can be hospitalized, and you definitely don't want to be a parent of a hospitalized newborn. Uh, Maternal immunization and the two types of infant monoclonal antibodies, they're both safe and effective. And our role as OBGYNs and MFMs is to, bring this into prenatal care early, answer questions, be empathetic about questions, and coordinate with our colleagues so that families hear consistent messages from their providers across the spectrum from prenatal care to postpartum period and through pediatric care. And so I think that, working together, counseling appropriately, collaborating, this can help probably significantly reduce RSV hospitalizations in the newborn period and have significant health implications for newborns.
I think that you brought up several points, and several of which we've discussed in other parts of the podcast since I've moderated a couple of these sessions. Monoclonal antibodies have been around for a long time, since the late 1990s. Do you think that saying that we have two new updated monoclonal antibodies that are similar to one that we have had for 30 years or 25 years maybe, do you think that's something that patients respond to? You mentioned newness was one of the arguments against these interventions.
Yeah, and by newness, I mean new virus that these antibodies are providing protection for, not newness in terms of monoclonal antibody technology. Yes. So thank you for bringing that up. No, this technology, as you acknowledge, has been around for a long time, and it's proven very effective. And it's great for many conditions, not just viral protection, but certainly is used across the spectrum in other types of healthcare treatment and prevention. But yes, in terms of newness, I mean, this is a new tool to fight this current virus.
Yeah, I mean, I think one of the arguments you hear about maternal vaccination in general is that most of them really aren't new. Flu and pertussis during pregnancy go back to the middle of the last century. But, do we know they have long-term effects? Well, for monoclonal antibodies for newborns, we know that they don't have long-term effects. They have benefits. And I think we made that pretty clear today. So anything else we want to bring up that we may have forgotten?
I would say that, I think the other important thing is just making sure that you're on the same team as your patient and be receptive to their own research, their questions. And, vaccine counseling takes time and effort. And, I think providing a constant reassuring voice is helpful to help patients make these important decisions for their family.
Well, thank you, Dr. Gimovsky, for this excellent discussion that we've had, and thanks to our audience for listening. Please remember to take the post-test and evaluation, receive the CE credit, and tune in for additional episodes within this podcast series.
Thanks again for joining us on MedEd Talks. To claim credit, please refer to the episode notes or the CE information. For other episodes in this series, search for RSV immunoprophylaxis.